So moving on to the first question. Choose the incorrect statement. Option A, clinical consequences of sarcopenic obesity are worse than those for either sarcopenia or obesity. Option B, hyperfiltration in obesity is primarily mediated by enhanced tubular sodium reabsorption, leading to reduced macular densa sodium delivery. Option C, obesity-related glomerulopathy, ORG, typically presents with gross nephrotic syndrome. Option D, obese persons are at enhanced risk for nephrolithiasis, predominantly uric acid stones. Option E, obesity increases the risk of renal cell carcinoma by inducing chronic inflammation and insulin resistance. Choose the incorrect statement. Musafar, please launch the poll. So poll time starts now. You will be getting 10 seconds. Musafar, you can close the poll and launch the result. Okay, so let's move on to the answer. So the poll results, yes, majority have opted for B. Let's see the answer to the question. So obesity-related glomerulopathy typically presents with gross nephrotic syndrome is the correct answer. That is the incorrect statement. So for discussing this question and answer, I invite Dr. Gopalakrishnan, sir. Over to you, sir.
Thank you, Jyothipriya. So I'll quickly discuss the various statements, the 5 statements that have been given in the first question. The first statement says that the clinical consequences of sarcopenic obesity are worse than those for either sarcopenia or obesity. At this point, I thought it's very important. Obesity, now it is kind of a very common generic term. Now, the recent research says that, there are multiple subtypes, the clinical obesity and healthy obesity. And one particular disturbing variant is sarcopenic obesity. It is a double whammy. It's a combination of muscle wasting plus obesity. So this combination, the people with this combination stands at a high risk for poor outcomes. It's very well established. The worst outcome is much worse than due to pure obesity or pure sarcopenia. The mechanisms and all will be beyond the scope of this particular discussion at this point of time. If time permits, I'll come to that later in the second part of the talk. Number 1. Number 2, the hyperfiltration in obesity. Yeah, you all know, like obesity-related glomerulopathy is multifactorial. The most important pathogenetic mechanism is hemodynamic alterations happening at the nephronal level. What happens is supranormal GFR, increased GFR. Why is it happening? In obesity, what happens is that enhanced expression of SGLT2, sodium glucose co-transporters in the tubular epithelial cells. So there is enhanced reabsorption of sodium from the filtrate. So the amount of sodium that is present in the early distal tubule, that is the macula densa, is less. When the macula densa portion, in that portion, when the filtrate sodium is less, there will be blunting of the tubular glomerular feedback, resulting in dilatation of the afferent arteriole, allowing more plasma to flow into the glomerulus. That results in hyperfiltration. This is the initiating event, and subsequently, so many other pathophysiological phenomena take place. Third statement, obesity-related glomerulopathy typically presents with gross nephrotic syndrome. It is the incorrect statement. I will not go into the details of it because, Dr. Jyothipriya will, in her talk, she will talk about this. I will omit a discussion on this point now. And obese persons are at enhanced risk for nephrolithiasis, predominantly uric acid stone. Yes. Why uric acid stone? Because urine pH in obese persons is acidic. Why is it acidic? There is less production of ammonium. Why there is less production of ammonium? Because of insulin resistance. Insulin resistance, less ammonium, less buffering capacity, so more acidic urine, so uric acid stone. That is true. Fifth statement, obesity increases the risk of renal cell carcinoma by inducing chronic inflammation and insulin resistance. It is very well documented. Obesity, it confers 1.5 to 2.5 fold increase for RCC. Why is it so? Again, it is due to insulin resistance that results in hyperinsulinemia and increased IGF-1, right? Insulin-like growth factor, and other growth factors. The downstream events result in proliferation, inducing molecules, enhanced expression that results in vasculogenesis and cellular proliferation, anti-apoptotic mechanisms, and so on and so forth. And of course, it's an inflammatory milieu, particularly IL-6 and TNF-alpha. So I'll stop here.
Thank you, sir. So moving on to the second question of the quiz. The question is, again, identify the incorrect statement. Option A, obesity confers additional risk for acute rejection following kidney transplantation. Option B, adiponectin contributes for glomerulosclerosis by enhancing production of TGF-beta. Option C, sleeve gastrectomy is the preferred metabolic and bariatric surgery than gastric bypass in view of higher risk of kidney stones and oxalate nephropathy with the latter. Option D, weight loss induced by GLP-1 receptor agonist is predominantly by appetite suppression and enhanced satiety. Option E, obesity is associated with increased aldosterone levels. Muzaffar, please launch the poll. So your poll time starts now. You'll be getting 10 seconds. Muzaffar, you can close the poll and launch the results. So there is majority has opted for the option A. So let's see what's the correct answer for this question. So the correct answer is adiponectin contributes for glomerulosclerosis by enhancing production of TGF-beta, which is the correct answer and the incorrect statement. So I once again invite Gopalakrishnan sir to discuss on this question and answer for the discussion. Over to you, sir.
Thank you, Jyothipriya. So let me quickly discuss these options. Like obesity confers additional risk for acute rejection following kidney transplant. Yeah, it is a very well-established fact. There are multiple reasons for this. You all know like the incidence of delayed graft function, DGF, is increased in obese kidney transplant recipients because of increase in the procedure time and technical difficulties in surgery and so on, multiple factors. That is number one. Number two, because of the obesity, the volume of distribution of immunosuppressants may be little erratic. There are some studies which show that for the same dose, the levels can be little higher because of interference of the lipid that is deposited in the hepatocytes, leading on to interference with the cytochrome P450 enzyme systems, leading on to increased levels of the immunosuppressants. On the other hand, there are some studies which show that because of different volume of distribution, there can be a subtherapeutic level of immunosuppressants and so on. So this kind of erratic, the levels of the immunosuppressants poses at a higher risk. That's number one. Second statement, adiponectin contributes for glomerulosclerosis by enhancing production of TGF-beta. It is a wrong statement. It is a leptin. Leptin is the villain hormone from adipocyte. Adiponectin is a friendly cytokine or hormone from adipocyte. So this is a wrong statement. The third point, sleeve gastrectomy versus gastric bypass procedures. Okay, there are multiple procedures. The procedures are classified into these two. And it's not just bariatric surgery. Please remember this terminology. It has to be MBS, metabolic and bariatric surgery. That is the preferred term. The essential difference is that, the bypass, it is a kind of a fat malabsorptive procedures. In any bypass procedures like Roux and Y and all that, there will be fat malabsorption. Whereas in sleeve gastrectomy, there is no fat malabsorption. Okay. When there is fat malabsorption, meaning there is a lot of fat in the intestine, it is not absorbed, which complexes with calcium. This is the process of saponification. So, normally what happens, oxalate is not really absorbed into the system because of the presence of calcium in the gut lumen, which complexes with oxalate. The calcium oxalate is insoluble and it gets excreted. Here, because of fat malabsorption, this calcium is already bound to the fat. It is not available to bind oxalate. So there is enhanced oxalate absorption into the system that results in oxalate stones as well as oxalate nephropathy. Okay. So it is more common with bypass procedure. In fact, the same mechanism in orlistat nephropathy also. And the fourth statement is very simple. The weight loss induced by GLP-1 receptor agonist is predominantly by appetite suppression and enhanced satiety. It is perfectly all right. And the fifth point is very important. Obesity is associated with increased aldosterone level. Yeah, this is a new finding, new knowledge. Normally, aldosterone, there are two important stimuli for release of aldosterone from the adrenal cortex. One is hypovolemia. The other one, increased plasma potassium levels. Now, there's a third important, the mechanism for enhanced aldosterone production as well as release. It is the adipocytes of obese person. These adipocytes elaborate what are called aldosterone releasing factors, ARFs. There are so many. They inappropriately enhance synthesis of aldosterone and release of aldosterone. So this is an important mechanistic linkage between obesity, hyperaldosteronism, and hypertension and poor cardiovascular outcomes and so on. Thank you, Jyothipriya.
Thank you, sir. So moving on to the third question. A 42-year-old man with a height of 165 centimeter and weight of 70 kg, BMI around 25.7 kilogram per meter square, with serum creatinine of 0.7 milligram per deciliter and urine albumin creatinine ratio of 780 milligram per gram. Renal biopsy shows features suggestive of obesity-related glomerulopathy. Which of the following investigations would provide the strongest additional evidence supporting ORG despite the patient's only mildly elevated BMI? Option A, bioimpedance-based body composition analysis. Option B, waist to hip ratio. Option C, leptin adiponectin index. Option D, subcutaneous fat thickness measurement. Muzaffar, please launch the poll. So your poll time starts now. Muzaffar, you can close the poll and launch the results. So majority have gone for option B in the poll. Let's see. So the correct answer is the leptin adiponectin index. See, this patient has only mildly elevated BMI, but the renal biopsy is suggestive of ORG. Now, the key issue is that BMI does not always accurately reflect the metabolically harmful adiposity, which drives the progression or resulting in ORG. So why leptin adiponectin index is the strongest evidence? The leptin adiponectin index combines leptin, as Gopalakrishnan sir already told, which is elevated in obesity and which is inflammatory hormone, and adiponectin is the protective one that is reduced in obesity. So a high leptin adiponectin index reflects metabolically active visceral adiposity and adipose tissue dysfunction, which are linked to the pathogenesis of obesity-related glomerulopathy. So considering the other option, a high leptin adiponectin index is the strongest additional evidence for ORG.